Good morning and welcome to today's seminar. The topic is occlusal concepts in complete denture. It will be covered in two parts. These are the part 1 contents. Now, occlusion is a factor that is common to all branches of dentistry. It is a term which is generally accepted to describe the contact relationship of the upper and the lower teeth. So there are numerous concepts, techniques and philosophies concerning the complete denture occlusion. Keeping up with the changes in this area is a challenging task. However, the basic principles of occlusion must be understood and applied regardless of what scheme is used. Coming to terminologies, articulation is a static and dynamic contact relationship between the occlusal surfaces of the teeth during function. And occlusion is the static relationship between the incising or the masticating surfaces of the maxillary or mandibular teeth or teeth analogues. Centric occlusion, the occlusion of the opposing teeth when the mandible is in centric relation. This may or may not coincide with the maximum intercuspation. And eccentric occlusion is an occlusion other than the centric occlusion. The centric relation, it's a maxillomandibular relationship which is independent of tooth contact, in which the condyles articulate in the anterior superior position against the posterior slopes of the articular eminences. In this position, the condyles are strictly restricted to purely rotatory movements. From this unstrained physiological maxillomandibular relationship, the patient can make vertical, lateral or protrusive movements. It is a clinically reputable reference point. Balancing or non-working side occlusal contact is the contact of the teeth on the side opposite to the direction of the lateral of the mandible. Whereas working side contacts are the contacts of the teeth made on the side of the articulation towards which the mandible is moved during the working side. And maximum intercuspation is the complete intercuspation of the opposing teeth interdependent of the condyle position. Coming to the differences between the natural occlusion and the artificial occlusion. So in the natural dentition, the teeth are retained by periodontal tissue, which is innervated and well structured. When the teeth are lost, the proprioceptive feedback is lost. So in a complete denture, all the teeth are seated on bases on slippery tissues. In the natural dentition, the teeth receive individual pressure of occlusion and can move independently. Whereas in the artificial occlusion, they move as a unit on their bases. In natural dentition, malocclusion may be uneventful for years, but malocclusion on the artificial occlusion evokes the immediate response and involves the teeth and the bases. Non-vertical forces on the natural teeth during the function affect only the teeth which are involved and well tolerated, whereas in the artificial teeth, the effect involves all the teeth and the bases and can be traumatic to the underlying tissue. Incising with the natural teeth does not affect the posterior teeth, whereas in artificial occlusion, it affects all the teeth on the base. In the natural teeth, the second molar is a favored area for masticating hard food, owing to the favorable leverage forces and power. Whereas heavy pressure on the second molar in the artificial occlusion will tilt the base, shift it, and if it is on an inclined plane foundation. In natural teeth, bilateral balance is rarely found, and if it is present, it is considered as a balancing side interference. In artificial teeth, bilateral balance is considered necessary for the base stability. In natural teeth, the proprioception gives the neuromuscular system control during the function, which avoids the prematurities and the interferences to establish a habitual occlusion which is away from the centric relation. With no such feedback mechanism present in the artificial occlusion, the artificial teeth, the mandible in which the function will end the chewing cycle in the most favorable position, which is near the centric relation. So in the broader sense, a complete denture should fulfill the aesthetic requirement, which is by the selection of the proper shade of teeth and arrangement of teeth. There should be harmonious function, which exhibits that the harmonious occlusal contacts in centric and eccentric maxillomandibular relation will have harmony with the neuromuscular mechanisms and the TMJ. And there should be maintenance of hard and soft tissue. Now, factors which play a role in this are the properly fitted bases, the correct jaw relation, and the arrangement of teeth for the best stability. So, Winkler is given ideal requirements of a complete denture occlusion. He said stability should be needed both in centric and eccentric relationship and in areas forward and lateral to it. There should be balanced occlusal contacts which are bilaterally for all eccentric and centric mandibular movements. There should be a tripod contact present. Unlocking the cusp mesiodistally. So this is to allow for the gradual but the inevitable settling of the bases due to the tissue deformation and bone resorption. Now there should be control of the horizontal forces. This is done by the buccolingual cuspide reduction according to the residual ridge resistance form and the interarch distance. And the functional liver balance should be favorable to the tooth, to the ridge and the crest position. Cutting, penetrating, shearing efficiency of the occlusal surface must be there. There should be minimal contact, occlusal contact because there should be reduced pressure for communicating the food. And sharp ridges or cusp and generous slices to shear and shred the food should be present, which will increase the masticatory efficiency of the complete denture occlusion. Now, this occlusal scheme requisite can be divided into three distinct units. It's the incising unit, working unit, and the balancing unit. The incising unit should be sharp. They should not contact during mastication. They should have a flat incisal guidance considering the aesthetics and phonetics. They should have a contact only during protrusive incising function. Working units should be efficient in cutting and grinding. They should have a decreased buccolingual. They should have a decreased buccolingual width. They should be placed over the ridge crest in the masticating area for the liver balance, and they should be placed on a plane which is as parallel as possible to the mean foundation plane. Coming to the balancing units, they should contact on the second molar when the incising units contact in function. They should have smooth gliding contacts for lateral and protrusive excursions. Now, Sears has given axioms which help us to guide and plan the complete dental occlusion since many years. He states that the smaller the area of the occlusal surface acting on the food, lesser will be the force which is required to crush the food, and therefore there will be less pressure which will result on the supporting tissue. If vertical forces are applied on the inclined occlusal surface, that will cause non-vertical forces on the denture. If vertical forces are applied on inclined supporting tissue, this will cause non-vertical forces on the denture bases. Vertical forces on the denture base supported by the yielding tissue causes the base to tether when the force is not centered to the base. And if vertical forces are acting outside the ridge, this will produce tipping of the denture. Coming to theories of occlusion, so the equilateral triangle theory was also known as the Bonville theory, according to which the distance between the condyle is equal to the distance between the condyle and the midpoint of the mandibular incisors. It forms an equilateral triangle of 4 inches. This theory proposed that the teeth move in relation to each other as guided by the condylar controls and the incisal point. Coming to the conical theory, which was given by R.E. Hall. Here, the lower teeth move over the surface of the upper teeth as over the surface of a cone, generating an angle of 45 degrees, with the central axis of the cone tipped at 45 degrees to the occlusal plane. The teeth of the maxillary denture would conform to a segment of the inner surface of an 8-inch cone. Coming to the spherical theory, here the lower teeth move over the surface of an upper teeth as the surface of a sphere with a diameter of 8 inches, the center being the glabella. And the surface of the sphere passes to the glenoid fossa or concentric with the articular eminences. This was based on observation of natural teeth and skulls. Coming to concepts of complete denture occlusion, the static concept and dynamic concept. The static concepts include centric occlusion, protrusive occlusion, right and left lateral occlusions. These relations must be balanced with simultaneous contact of all teeth on the both sides of the arches. Cuspal incline should be developed so that the teeth glide from the centric occlusion to the eccentric position without interferences and without tipping or rotation. A dynamic concept is primarily concerned with the opening and the closing movements which involved during the mastication and swallowing. Jaw movements and tooth contacts are made as the teeth of one jaw glide over the teeth of the opposing jaw. Free movements are described as those movements of the mandible which occur when the teeth are not in contact. So the occlusal concepts in complete denture rehabilitation. In 1972, there was an international workshop which was held at University of Michigan School that devoted the 4 days to the subject of complete denture occlusion. And they said that occlusal rehabilitation in complete denture falls under unbalanced articulation, balanced articulation, linear or monoplane articulation, and lingualized articulation. Now, based on further literature, there are other occlusions such as balanced occlusion, monoplane occlusion, lingualized occlusion, organic occlusion, neutrocentric occlusion, linear and physiologically generated occlusion. Coming to a monoplane occlusion, it was advocated by Jones. It's an arrangement of denture teeth in a single plane that is medial-laterally and anterior-posteriorly flat monoplane articulation. Here, 0-degree teeth are used. Now, in the posterior occlusal plane should be evenly divided between the spaces of the upper and the lower ridges. The occlusal plane should be parallel to the mean foundation plane, and the occlusal plane should fall at the junction of the upper and the middle third of the retromolar pad. In this scheme, the occlusal forces are centralized. The advantages being it is more adaptable to unusual jaw relations. There's a sense of freedom because they do not lock the mandible in one position only. It can be used for patients who have unfavorable prognosis, and it's easy to arrange and less time consuming. The disadvantage being the flat premolars appear less aesthetic, and it has reported less masticatory efficiency. Coming to the lingualized concept, it was first described by Payne, and it is a form of denture occlusion which articulates the maxillary lingual cusp with the mandibular occlusal surface in the centric occlusion working and non-working mandibular position. This was in an attempt to maintain the aesthetics and the food penetrating advantages of anatomical tooth form while maintaining the freedom of the non-anatomic tooth form. In this occlusion, we can use anatomic, semi-anatomic teeth, or even 0-degree teeth can be used for the lower mandible. This type of tubing is a motor-pestle type. The forces here are centralized and there is a reduced frictional force because the surface area contacted is less. It's indicated when high priority on aesthetics is needed in class 2 jaw relation and when a complete denture opposes a removable partial denture. Its advantages are both anatomical and non-anatomical forms are retained. Cusp form is more aesthetic. There is a good penetration of the foot bolus. Bilateral balance can be obtained for a region or around the centric relation, and vertical forces are centralized on the mandibular teeth. So, in the lateral excursive movements, the clearance between the maxillary and the mandibular buccal cusp increases the lever stability. Coming to a study where they compared lingualized occlusion with monoplane occlusion. Here they, for the lingualized occlusion, they use 30-degree maxillary teeth and mandibular non-anatomical teeth. And for the monoplane occlusion, they use 0-degree teeth. So here the 30 patients were included and 13 patients got the lingualized occlusion denture first and 17 patients got the monoplane occlusion denture first. And after 3 weeks, it was interchanged. Here they measured the number of adjustments, the chewing ability, and the reason of preference. So those who selected lingualized occlusion said that those dentures, they chewed better, fit better, they were more comfortable, they looked better, and the speech was better. Those who preferred monoplane occlusion said that they were more comfortable, they fit better, and could eat better. The study concluded that 67% preferred the lingualized occlusion due to the improved masticatory abilities and the appearance of the denture and comfort. Coming to organic occlusion, The functioning element of the organic occlusion is the stem cusp in the fossa. The stem cusp of the maxillary lingual cusp and the mandibular buccal cusp. Now, this occlusion is based on the muscle and joint determines that the mandibular position without the teeth guidance and the teeth and function should always be passive with the part of the mandibular movement. Here, as the jaw moves from the centric occlusion, these cusps pass through grooves and prevent the occlusal interferences. The working grooves are transverse while the idling grooves are oblique. Here, the posterior stem cusps protect the anterior teeth in the centric occlusion, and the anterior teeth protect the posterior teeth from the eccentric or the horizontal stresses. Coming to neutrocentric occlusion, it was given by Divan in 1954. Now, there are two key objectives of this occlusion. It is neutralizing the inclines and centralization of the occlusal forces. 25 years clinical evidence has proved that this dentures made by this scheme are satisfactory in preservation of the ridge bone and have good appearance, and adequate speech and mastication is possible. This concept of occlusion eliminates any anterior, posterior, or mediolateral incline of the teeth and directs the forces of occlusion to the posterior teeth. And there are 5 factors in this occlusal scheme as position, proportion, pitch, form, and number. Now, in position, the author recommends the positioning of the posterior teeth in an as central position in reference to the foundation and in how much the tongue will allow. The teeth should be set within the foundation bounds whenever possible. Coming to proportion, a reduction of 40% in the tooth structure in the width is possible without serious diminution of the foot table. It is necessary to establish centralization, or as there will be encroachment in the tongue space. Frictional forces are also reduced by reduction of the tooth width. Coming to pitch, pitch is synonymous with the tilt or inclination. Here it aims to reduce the aim is to reduce the pitch as found in the natural dentition and to parallel the pitch of occlusion plane that with the maxillary and mandibular base plane. The compensatory curve should be neutralized so that the posterior teeth are set on the plane rather than a spherical surface. In form, it should be devoid of projecting cusp and should be present in a single plane. This will reduce the destructive lateral forces and direct the masticatory forces perpendicular to the support. In number, the posterior teeth were reduced from 8 to 6. This decreased the magnitude of the occlusal force and centralized it to the second premolar and first premolar region. The advantages of neutrocentric occlusion is that it is simple and requires lesser precise records. The teeth arranged in this are easier to adjust, and by removing the inclined lateral forces which are destructive to the residual ridge are reduced. It can be used in class 2 and class 3 and crossbite cases. It provides an area of closure and does not lock the mandible into a single position. The disadvantage being that because here there's no incisor overlap and no posterior cusp, it is less aesthetic, and the flat nature of the teeth can result in impaired mastication. There was a study which was conducted to evaluate the masticatory performance and the maximum occlusal force. It was compared, neutrocentric occlusion and bilateral balance occlusion were compared in 10 patients, and the masticatory efficiency of the food used was roasted peanuts. So the study concluded that there was no significant difference in the masticatory performance and in the maximum occlusal forces. But whether it is bilateral balanced occlusion or neutrocentric occlusion, a 60 chewing stroke provide a better masticatory performance than 20 or 40 chewing stroke. Coming to lineal occlusion, so a line of occlusal contacts in one denture arch opposing a flat occlusal table in the other dental arch has a potential of creating the smallest lateral component of force against the denture base. Since the area of contact is minimal, the frictional resistance is reduced. So here in a cusp type occlusion, and any eccentric mandibular movements results in a significant lateral movement component of force to the denture basis. When non-anatomical occlusion eliminates most of the lateral components of force. The frictional resistance of the buccal and the lingual contacts probably contribute to the additional denture-based movements. In the lineal occlusion has a less potential of creating uh, the lateral component of force against the denture bases. Since the area of contact is very less, the frictional resistance is less. The line of occlusal contacts, there is no change from the location to the centric to the eccentric position in the lineal occlusion. And when in centric, only vertical and balanced forces with a minimum contact area are developed. For locating the line of lineal occlusal contact, it can be in either arch, and the decision depends on the factors which affect the denture stability. Coming to linear occlusion, the occlusal arrangement of artificial teeth is viewed in the horizontal plane, wherein the masticatory surfaces of the mandibular posterior artificial teeth have a straight, long, narrow occlusal form resembling that of a line, usually articulating with the opposite monoplane teeth. Here, the teeth are arranged on a flat plane which extends from the tip of the maxillary central incisor to the top of the retromolar pad. Coming to physiologically generated occlusion developed by Meringer, he said to harmonize the complete denture occlusion, neuromuscular system, and the temporomandibular joint. In this denture, first the complete denture is fabricated till time, and only the maxillary complete denture is processed. Then a conical disc is attached to the parietal region of the maxillary denture, and the lower denture base is attached with plexiglass, followed by fabrication of a plaster and talc, and by attaching the central bearing device which fits into the upper conical device. A plaster and talc index is made by asking the patient to make the chewing and the swallowing movements, which creates functionally generated pathway. The maxillary cast is then poured for the generated pathway, and the lower teeth are arranged accordingly. Coming to the concepts to attain non-balanced occlusion, there are 5 concepts. First is the Pound's concept. He said that the maxillary posterior teeth should have sharp palatal cusp, which should occlude the widened central fossa of the mandibular posterior teeth. Now, in the centric occlusion, the occlusal forces are directed towards the ridge, and in the right lateral position, the buccal cusp on the working side are out of contact, uh, and the force is directed towards the lingual side of the lower ridge. Coming to All's concept here, maxillary posterior teeth should have a 33 cuspal form with a full cold occlusal surface. In the centric relation, the contact forces are directed towards the ridge, and in the right lateral position, the canine guided occlusion dislocates the posterior teeth. Coming to Hardy's concept, here he has used non-anatomical maxillary and mandibular posterior teeth, which are arranged in a flat plane with a minimum overbite. In centric occlusion, the masticative forces are directed towards the ridge, and in the right lateral position, only the buccal cusp on the working side contact if the path of the condyle is not parallel to the occlusal plane. Coming to Sears' concept, he has developed occlusal pivots when the pivots are placed in the mandible in equilibrium by maintaining the occlusal load in the molar region. Now here in the centric occlusion, the occlusal forces are directed towards the ridge, and in the right lateral position, they are only the working side pivot will contact if the path of the condyle on the balancing side is not parallel with the occlusal plane. Coming to KURTH'S concept, he said the artificial posterior teeth are arranged with incorporating the reverse lateral curve. So here in the centric occlusion, the contact forces are directed towards the lingual side of the lower ridge, and in the right lateral position, the occlusal contacts are directed towards the ridge. Are directed towards the ridge. Balanced occlusion is defined as the simultaneous contact of maxillary and mandibular teeth on the right and left side in the posterior and anterior occlusal areas in centric and eccentric positions, developed to lessen or limit the tipping or rotation of the denture bases in relation to the supporting structures. It is unique to the complete denture. it became apparent that even a grain of food on the working side eliminates the balance on the non-working side. And it was aptly summarized by Shepard as enter bolus exit balance. Now, when the teeth are brought in contact at any relation of the jaw, at least a tripod type of contact of the teeth will provide stability to the denture base. The significance of this is it affects the stability of the denture bases, and Brewer said that masticated tooth contact occurs for 17 minutes in a day and 4 hours of a total tooth contact of other function. Therefore, maintaining stability is important for this 4 hours. If there is no balance present, the bases could shift, tip, or torque on the foundation during the eccentric movements and cause inflammation, which can lead to accelerated bone resorption. Therefore, balance occlusion needs to be considered important from the point of view of both functional and parafunctional movements. This will be continued in detail in part 2. Coming to literature review, there was a study where difference was in the quality of life of the patient and patient satisfaction between non-balanced and bilaterally balanced occlusion, a parallel randomized controlled trial. So in this, they measured the quality of life by the oral health impact profile and patient satisfaction by the visual analog scale. Now, 30 patients received non-balanced occlusion and 30 patients received bilaterally balanced complete dentures. This was observed at 2, 3, and 6 months after the denture insertion. Now, in this study concluded that the quality of life and the patient satisfaction between the bilaterally balanced occlusion and non-balanced occlusion was statistically similar. Coming to a systematic review of choosing the denture occlusion, in this systematic review, 17 articles were taken on occlusal schemes like bilateral balance occlusion, lingualized, canine guided occlusion, posterior function occlusion. The study concluded that no scheme is more superior to the other when using the anatomical tooth form. Lingualized can be helpful in resorbed ridges for the masticatory efficacy and even in providing bilateral balance. Now, it also concluded that bilateral balance is one preferred choice, but not for all ridge types. Canine guided occlusion is a most preferred occlusion scheme for dentulous situation and needs more evidence-based research for to see whether what effect it has on denture stability. And use of alternate unbalanced scheme can produce a satisfactory clinical outcome. Coming to another systematic review where they have seen the effect of complete denture on the function. In this review, 7 articles were included and it saw the effect of balanced occlusion versus canine guided on functional ability or the quality of life of the patient. The quality of the studies which were included was poor to moderate, and with the majority of the study, they lacked the randomization, blinding, and the demographic data. The occlusal concept of canine guided and balanced occlusion have simultaneous bilateral contacts in centric occlusion, but manage guidance in very different way. It has been suggested that the canine guidance is unsuitable for the provision of the complete denture, as it is likely to play a significant role in the tipping forces of the denture. This study, there was a lack of consensus among the articles as to how and what degree of denture occlusion might influence the denture stability, patient chewing abilities, and quality of life. These are my references. The part 2 will contain about balanced occlusion, the significant advantages, disadvantages, the concept of balanced occlusion, factors, context in balanced occlusion, selective grinding, and review of literature. Thank you.